impacted tooth and ankylosis. Are you interested? Why? Because you must have some experience. Is it good experience or bad experience? Bad. How about this? Canine. How about this? First molar. How about this? You know, some switched canine and premolar. Those things. What are you going to do if you see some patient like that? Try to call your oral surgeon or send the patient to your next orthodontist so they get into trouble. Did you experience any kind of failure dealing with ankylosis? Maybe yes. Maybe yes. It's not only me. You must have had some problem, trouble dealing with impacted tooth. Maybe there is a reason. Maybe there is a reason. Okay, technically, it's impossible to put the brace bracket on the impacted tooth. It's always button. And you cannot engage a wire. Only thing is to engage a power chain or something. So your tool is very limited. If it's really terrible, let's get back to the basic. Try to figure out what we can do right from the bottom. Eruption, well, we take it for granted. Eruption must take place, but it's unbelievably complex procedure. How come maxillary canine comes down? How come mandibular canine comes up? Why? Because of gravity? Because of some force? No, there's no force. How come canine erupts next to first premolar, next to second premolar? How do they know their order? Okay, I am canine. I have to stay here because she's 10 years. I have to stay here for 2 more years. Do they have a brain? How come all of this is possible? Tooth eruption appears to be a programmed procedure. There's a program here. Not only here, also here. Brain will give an order. Now it's time for you canine to come up. So it has a lot to do with the biology. What kind of biology? Oh my God. There is all this abbreviation, CSF, VAGF, rank. You don't have to take picture. You are not supposed to do anything with the VAGF today in your clinic. You don't have to take a picture. It's a basic instinct. Whenever I show you some table, oh my God, I have to take a picture and memorize it. Okay, it's not mechanical. It's a chemical and soft tissue involved here. It's not, there's no force involved. It's some program. What kind of program? Each tooth will have some order from the top or from the bottom. On crown and the root. At some time point, we got some order. We get some order. From the top, okay, it's time for you to come up. And in the bottom, it's time for you to grow something in the bottom. Make some root from the ground. When does it happen? We don't know yet. And it's very obvious that it's molecular, not mechanical, molecular. When does it happen? When it is supposed to happen, it happens. When is it? For example, canine, for canine, it's 12 years. Okay, no one knows if you turn 12, but if you turn 12, something will give you an order. Canine, please do something. That's what's happening. You already start to get bored. I know. Biology is very distracting, especially among orthodontists, because orthodontists are interested in what? Making money. not biology. You want to make some money. If I start to talk about VGF, whole lecture will be like this. It will be emptied. But let's warm up something. As an orthodontist, at least to gain some money, we need to know something. Let me ask you one question. What kind of pathology, abnormal finding do you find in here? 60-year-old female, something, tell me something. Do you find the mesodense? Correct? Okay, that's one thing. We pulled out the mesodense because there's an impacted tooth right there. We pulled out the mesodense and we were doing some protraction, headgear, face mask. And in the meantime, I took a panoramic view. Do you find something? Mesodense is gone. Do you find something? Oh my God, I found something. Something is not right. That's why I took additional CBCT. And I found what? Found what? Do you see the supernumerary tooth underneath the canine on the right side? What kind of clue was that? Back in here, what kind of clue was that? Supernumerary tooth was so small. Regular orthodontists would not be able to recognize if something is wrong. But I was suspecting something is wrong. Why? Have a look at the right and left canine. They are not symmetrical. Okay, Dr. Lee, so you focus on symmetry between right and left side? No, it's not all. Have a look at the root. Root is forming, crown is not moving, as if there's something on the way. That's what intrigued me. And I took CBCT and found something. 10-year-old boy. What do you find? Is there anything wrong? Okay, I know there's a limited space for upper canine. That's one thing. We are all experts in space analysis. What else? Do you see lower molar is terrible? Really terrible? My diagnosis is ankylosis of the first molar. Oh my God. It was ankylosed. It was ankylosed. Clear lamina dura, everything very beautiful, periapical view. How come it's ankylosed? Because the eruption is slow? Maybe yes. What is the definition of eruption? Eruption takes place only when crown is complete. Now, until the crown is completely formed, the position will be exactly same. So we use, for example, the third molar tooth germ for our superposition for structural method, correct? Are you orthodontist, by the way? Structural method, superimposition. We use a tooth germ, believing that the tooth germ is not going to move until they erupt. So the crown position will be same, but when the root starts to form simultaneously, there must be something on the top. Now, crown, I'm not going on the ground. It's just like there is some basement floor, and they stand up. And then, if root is forming without crown displacement, obviously there is something wrong. Do you understand? This is biology. Biology. I'm not going to talk about CSF. I'm not going to talk about VAGF. They are very boring. The core idea is that this is a collaboration between here and here. Something has to sprinkle magical as magical as something to start the bone resorption here. Something has to initiate the root formation at the same time, but the root is not going underground. If you find the root is going underground, then eruption process has been messed up. Do you understand? This is the biology. So from now on, everyone in this lecture, please, whenever you start to see panoramic view, don't only focus on the space. You start to think about biology, right? Even without your knowledge, many cells, a lot of cells here, they are yelling. They are yelling, oh my God, Dr. Lee, I want to go up. Something is holding me back. Oh my God, do you hear the sound? Do you hear the sound? I hear that. I hear that. That's as if it's an S to S yelling. That's a normal eruption that takes place from Ebola stage 5 to 6. Okay, hey Dr. Lee, that's too sensitive or complicated or sophisticated. We can't just let it go without that kind of sensitive diagnosis. What if you don't pay attention? You don't pay attention. Then patient comes to university hospital from a local clinic. Why? You see there's a button saying that she has been under orthodontic treatment, care, and she was sent to the university hospital. Why? Because something like this happened. Why did it happen? It just happens. It just happens during eruption. Now the orthodontist is in big trouble. So the story is, hey, Dr. So-and-so, my daughter has been under your supervision for the past 2 years and you didn't notice my daughter's center inside is disappearing. You didn't know that. Why? Because he didn't take panoramic view on a regular basis. He was accused. The patient get mad. What are you going to do? So, if you don't pay attention, something like this happen, and then you will get into trouble. Do you understand? You really have to pay attention. According to the literature, Kuro reported, in cases of an impacted canine, nearly 50%, I'm not talking about 5.5, 50% of impacted canine caused root resorption of adjacent teeth. That's traumatic. It's very high percentage. So we have to pay attention. Do you understand? So I'm going to talk about why I already talked about why we have to be serious about diagnosis of impacted tooth. And second, I'm going to talk about stem cells. Oh my God, it's going to be very boring. Stem cells. Are you interested in stem cells? Have you ever manipulated stem cells in your clinic? Raise your hands. Have you ever do something like LU, platinum-rich plasma or something like that? Have you ever manipulated stem cells in your clinic? Raise your hand. You are all lying. You are a stem cell specialist. You have manipulated stem cells every now and every day, every night. You are manipulating stem cells. Because you have a lot of stem cells in your teeth. By giving force on your tooth, on your teeth, you are manipulating them. Do you believe me? You are stem cell specialists, and the stem cells in the intraoral area is the most powerful and potent stem cell in entire body. That's very true. Do you understand? Especially the follicular stem cells and apical papillary stem cells. Those are really super powerful. They keep growing over and over. And who is dealing with the apical papillary stem cells? What's the profession? Orthodontist. Only profession that deals with the papillary stem cells, orthodontist. Did you know that? Oh my God, I was a stem cell specialist. That's very true. You are. Now, let's move on to biomimetic. Whenever we find impacted tooth, we start to refer the patient to oral surgeon, periodontist. Please do something for me. I'm in trouble. Let me tell you something. Are we root resorber or root creator? We are root resorbers, right? Whenever we do orthodontic treatment, we resorb roots. Do you agree? But we can grow the root. We can grow the root. Have a look at the central incisor. No root at all. Compared to the other side, this one has no root. So question is, do we have to do something right away or do we wait?
Em ngồi sang đây một xíu để em quay cho dễ.
Do we have to move the tooth with no root at all? This is very common in cases with inverted impaction because of limited space, correct? And we are worried. We are worried. Okay, maybe we have to wait. My question: what happens if you wait? What happens? There's a limited space. There will be a hurdle, obstacle for the root formation. To make the long story short, I did the surgical opening right away with some device like this. The main thing is I wanted to produce vertical force. Okay, labial liberal arms. What matters is a vertical force, not waiting. Not waiting. Not waiting. In the meantime, I'm worried. I was able to align. What about the root? Now normal. What happened? Is it magical? Is it magical? No. I try to read the underlying biology. They are yelling, "Hey, Dr. Lee, please sing." Who is that? Apical papillary stem cells. Aloud. They are yelling. Let's get back. Here, do you see the papillary stem cells yelling at you? "Hey, Dr. So-and-so, please do something for me." And I did something so that they can work. Otherwise, they cannot work. So this is it. So we can grow root. We can grow root. Whenever we do orthodontic treatment, do we resorb the bone or make the bone? We resorb the bone. We are bone resorbers, removers, or bone formers. What is it? Which side are we? We always resorb the bone. Yes or no? Again, this thing. Now, from now on, whenever we run into impacted tooth, basically, I think about biomechanics, force system, vector, here and there. And also, I want you to read the biology. Basically, we have to rule out the possible ankylosis of the first molar. If it's really ankylosis, it's a deep trouble, not easy. And what concerned me was the bone on the distal side of the second premolar. we are dying to pull out first molar, but if we do so, all of a sudden the second premolar will be wobbly. Do you agree? Okay? Do you agree? Because oral surgeon, they cannot pick it up as if nothing happened. They will grind the bone on the side. As soon as you remove the first molar, there will be huge bone defect on the upper side and on the distal side of the second premolar. And there was serious bone defect on the distal side of the second premolar already, even before the extraction. After the extraction, I'm 100% sure second premolar will be like this. And you lost first molar, and you are just about to lose the second premolar, and you are like what? Butcher? You are a killer of the tooth, or what? Huh? That was a very, very hard part. We need to rule out the possibility of the ankylosis of the first molar. How? I don't know. We have to read the situation. If it's a pure vertical impaction with no obstacle on top, it's more of ankylosis. If it was mesial inclined, and obviously there was some reason for non-eruption, then less chance of ankylosis. Very hard decision to make. Very, very hard decision. But because of the worry about the bone defect, we have to make some table. The pros and cons, do good points, bad advantage, disadvantage of each extraction options. And finally, we decide to pull out the 46 first molar. No, sorry, 47 to save 46. Extraction of lower septum, this one. Saving first molar, just like that. Okay, we were able to save. Now it's like switching between first and second molar. Switching. And what's the biological meaning of that kind of switching? Going through all these differential diagnostic procedure. What matters is that bone, the distal side of the second premolar, bone. We were able to make the bone. First thing, we didn't have to pull out the first molar. And second thing, we were able to hold. Do you hear the cells? Do you see the cells? On the side of the first molar, there's a lot of cells. We are not supposed to give an incision. We are not supposed to reflect the flap. We are not supposed to give bone graft material on it or anything, because that's naturally a lot of cells. Naturally, a lot of cells in there. We wanted to keep this area uninterrupted as much as possible. Then they will do the work under one condition: no traumatic occlusion, no trauma or anything. They will make the bone, and this is simple switching. Still, it's an oval bone. Let's have a look. Following the first premolar extraction, we close the gap, midline match it. Good looking. He was good looking from the first place, by the way. So what is really good looking is the bone structure after treatment. So we can make the bone depending on the way how you manipulate the situation. What was the condition? We didn't do anything in the local area. We keep them clean and tidy, silent, with no trauma, anything in here, so they are able to work with no traumatic occlusion. This was published long ago, to year 2015 in AJLDO. So if you need a reference, go find the article. What matters is we can grow bone. But it depends. So let's move on to biomechanics. we had a little bit of a review on the biology, just a little bit. Think about the cells in local area. There must be some cells, especially when the patient is young. And what are the available force systems? You Google it, impacted tooth, treatment, surgical opening, Google it. Tons of information, have a look. Opening, chain, power chain, to occlusal level, vertical. 99.999% of all this information are exactly same. Opening, exposure, button, chain, pull it from the occlusal side. But that's very strange. They were impacted because there was something on the erosion path. If you give a vertical force, can they erupt? They were not able to come up because there was an obstacle on the top. And we are pulling from the top. Does it make sense? Does it make sense? Surgical opening, vertical traction is a cure for all. You Google it, and you don't find any value of the information other than surgical opening, traction, chain, power chain, use Ormco. Somebody says Rocky Mountain is better. No, it's not important whether you use Ormco or Rocky Mountain. What matters is your force factor. Let me give you an example. So the same situation, troubled. Now, it's going to take us 1 hour more than the whole night to think about possible treatment options for her. Maybe extraction of a central incisor, rescuing the canine. But if you pull out the central incisor, you have to handle canine position, and also the empty canine space must be filled up with dental implant or molar protraction. The next story will be even more complicated. So what are we going to do? How about if we save the canine? You want to save the canine? Anyone in this room want to save the canine? They're bumping ahead at each other just like that. Okay, we do the surgical opening. This is what it looked like. This is what it looked like. If you want to save the canine, any one of you would try vertical traction? Are you mad? You want to try vertical traction? You want to get rid of the central incisor? Does Google help? Does Google help? Is the Google search helpful? Is the textbook helpful? This is the reality in current orthodontics. Everyone is crazy about clear align, spending your money 3D printing AI. Does AI help? Do the chat GPT, what am I supposed to do in here? Input the picture and then ask GPT. Get something out of it. We want to back it up. We want to push it upward, even upward. Google tells us it always has to be vertical traction, downward traction. But I will push it back using some kind of a lip bumper. Now, power chain is coming from the tooth, go around the edge of the lip bumper, and it is engaged in the clear button on the labial side of the lip bumper. So basically, the force given to the impacted canine is an upward and backward force, intrusion force. Intrusion force to a deeply impacted canine. Is it possible? Yes, possible. It's possible, right? And then intrusion, and then on the side, your canine is getting out of the battlefield. That has to be the first step of the treatment. Have a look at the auxiliary wire coming from the premolar and molar area. The way how it's activated is just like this. It's poking through the vestibule and dragged all the way down to the canine. So the canine will be pushed up, not down. Pushed up. And then on the side, toward the side, we were able to save the canine. We still bypass the central incisor because the central incisor is very short root, and try alignment just like that. And we were able to finish. There's a small there's a small intermaxillary gap between upper and lower canine that was very intentional because if it's a fresh canine rescued from the battlefield, we want to make sure that we don't have traumatic occlusion because the bone is not really mature many times. So that was very intentional. Is she happy? Of course. I am happy too. Are you concerned? What about the central incisor? Root length is exactly the same. What is your expectation of the lifespan of the central incisor? Is it going to come out in the next few years? No, I don't think so. Maybe more than 10, 20, 30 years, as long as she brushes well. This is what we can do as an orthodontist. If you pull out the central incisor, the next story will be even more complicated. Dragging the canine out to the central incisor position, and how to fill up the empty canine space, aligning lateral and central, tooth shape, additional laminate or crown. Very complicated. 1.5 years follow-up. Same. So as long as there's no external trauma, stimulation or something, it's supposed to remain same. Next, so I used vertical, upward single force. And another trouble is that because we always use a single force for impacted canine, that causes uncontrolled rotation nearly always, without exception. And my question is rotation always terrible or bad? Let me show you the next case that I showed you in the beginning. This was also published in AJOTO. This is not just a case report. I tried to embed some very important biomechanical principle in this article. So please go to the article, try to have a very careful read on this article. Now, canine, they are terrible. But then again, what you have to do is to, and there's one more thing, lower molar ankylosis, possibly. Is it really ankylosed? I suspect ankylosis. Let me tell you, ankylosis is never ever diagnosed from the panoramic view. Never, hardly diagnosed from CBCT. So you need a little bit of speculation. What's going on? What happened? You really need some speculation in order for you to diagnose ankylosis properly. Now, this is a situation. Now, we normally call it transposition. What I want you to do is to decide something from a center of resistance perspective. Do you understand? Center of resistance perspective. So if you take a CBCT, try 3D rendering, and then try to pinpoint, estimate the center of resistance position. And then if you compare the center of resistance of a canine and also first premolar, then you know they are not transposed. Correct? We need this kind of a view from the top, from the bottom, from the side. That's the major advantage we can get from the CBCT rendering. So it's not really transposed. Then you think about what kind of movement you will need. We need rotation. Canine rotation out of the battlefield. What kind of force system you need? We need lateral force. Okay, try to reproduce. And you want to Google it? You want to use a ChatGPT to find your own appliance? No. You design lateral force. And based on yellow arrow, you will design your appliance. In order for me to produce lateral force, I'm obliged to make some appliance, just like that. First, intra-alveolar lateral force with no vertical force involved. So there's nothing vertical involved in here. And then, vertical force. So we were able to save the canine just like that. It's rotation, uncontrolled rotation around the center of resistance. That was very useful in this circumstance. And what about the lower molar? It's even more submerging. We tried subluxation only once, and then it didn't work. She's turning like 11, 12, so we pulled out the lower first molar and pulled the second molar forward. I did not hesitate for a long time. We decided to pull out the lower first molar. Why? Because I am so cruel. Am I cruel? I want to make the right decision at the right time point. Now she's happy. A little bit bone loss around the canine. We'll have to see. Before and after. There's a very thin bone covering on the labial side of the canine. So we are a little bit relieved, but we still have to pay attention to that. So this is my remedy for possible ankylosis in a grower. Through all possible, measures you can ever take, you do speculation and then you suspect, assume ankylosis. Then you try subluxation one time, and then if it's really ankylosed, you better go directly to radical extraction and something, molar protraction that I'm going to show you from now on. Otherwise, if you just hesitate, okay, what am I supposed to do? Extraction or not? Wait. If you wait, you make it worse. That's the situation, just like the root resorption case. If you wait, doing nothing, you are making it worse. Because of this, related to ankylosis. I took this picture from one of my colleagues' textbook. Even if I keep saying this is going to be detrimental, no. You really need solid evidence. This guy did a great job for this huge posterior open bite, pulled everything during growth. If it's re-ankylosed, it will become like this. 4 years, 7 years. So all of your effort is in vain, ruined. So you really have to make clever decision. You can say, hey, I did my best. This is the best. But I paid $10,000 to you, Dr. Lee. I paid $5,000. And you said was not useful. Was painful for the past 3-4 years. All my pain is like nothing. No, you cannot possibly defend yourself. But in this case, after 4 years, just because I made the decision of extraction, and after the third molar eruption, we have a very good biomimetic, as if nothing had happened before. Good occlusion on the right side. She seems to be happy. I don't know if it's natural smile. She's really happy. So this was an example of single force. 21 male. He had nothing to do with the impacted tooth, but he was referred to orthodontic department from prosthetic department. You know why? The dentist was not able to do anything. Crown and bridge, dental implant, whatever. That's a scissors bite. And upper left, upper right second premolar is lingually positioned, and we do this kind of occlusogram. If you want to align the teeth without flaring, basically you have to distalize the premolar. Then you don't even have the enough space for the dental implant for the first molar. That's what we found. Okay, basically we have to distalize lower molar. Then there's a third molar. Of course, we have to pull out the third molar. Then thinking about his age, he's only 21 years old. He has more than 50, 60 years to go for his lifetime. Not like me. I have much less life expectancy. Still less than you. But he's got a very long lifespan. How about if we try to save the third molar? Save the third molar. Is it possible? We cannot even see third molar. It's impacted. And it's severely inclined to the medial side. Let's go back to biomechanics. Single force may not be good enough. We need a lot of moment. We want to turn it upside down. We want to turn it upside down. Maybe two forces would be better. So strategically, I asked the surgeon and I left a note. Hey, Dr. So-and-so, I will place the mini screw on the retromolar area, and please reflect the plate all the way down the side so that I can attach another button on the medial buccal cusp. I need 2 points of force application, and we did it. Now, space distribution, pulling the premolar segment backward to find the space for the alignment, asymmetrically between right and left side. Now, upper first, as you know, upper first molar is intruded for the scissors bite correction, like the submarine. Below the gingiva, there is a power chain from the distal side of the third molar to the retromolar pin. Another power chain is coming out of the medial buccal cusp of the third molar. Now the power chain is engaged on the lingual side of the second molar. This way, we are using two forces to rescue the third molar, turning it upside down. I assumed that single force would not be good enough, so I used 2 forces, and now second molar and third molar in place just like that. And what is the main point in here? We were not able to attach a bracket. We were not able to attach a tube. We were not able to engage a regular wire. Using 1 or 2 single forces, we still are able to try major root movement. Have a look at the way how the third molar is relocated from the panoramic view and also from the lateral cephalogram. This is the way how the third molar has moved. It's a root movement, correct? Not distal uprighting. Major root movement of the third molar, and the center of resistance was also relocated forward. What kind of appliance did I use? Is it bracket from Onco, very brand new, very expensive, very shiny, slick? It's a lingual button. And forces, what matters is the biomechanics. I try to use some combination of the force systems. So the point is, some of these available type of tooth movement in impacted canine, impacted molar, impacted tooth cases, you can possibly try anything. Tipping, translation, intrusion, extrusion, depending on the way how you design the force vector. So you will think about the force system. Force and moment many times, sometimes both of them. Now let's move to the next topic. Are you bored, by the way? This is deadly time right after lunch. May I dance? May I sing for you? It's a deadly time, deadly time. I heard that Dr. Who's that? Dr. Someone singing on the stage that was not very beautiful, so I will not do that. Timing. Eruption is a timely, takes place very timely manner. 12 canine, 11 first premolar. There is a signal. Okay, it's time for you first premolar. It's time for you canine. It's time for you lateral incisor. This is dog's specimen. If you magnify this at the time of eruption, there is an osteoclast, and the osteoclast is differentiated at some time point. Who is manipulating the osteoclast? It's a central regulation. Something is secreted from the center, and then on the top, they will receive the signal. The tooth follicle or the bone area, they will receive, okay, it's time for me to develop some osteoclast. Hey, you gather here and do some work. And that's what's happening. There's no force involved here. Let me ask you one question, applied question. What if you just grind the bone on the top to facilitate the eruption? Then you mess up everything on the top. You kill the cells, right? Think about your clinical behavior from a biological standpoint. This is very natural, and then you won't disrupt the biological process. We are talking about the treatment timing. Here it is 17. Crazy girl with crazy canine. Do you like it? Crazy girl with crazy canine. 17. 17 is still teenage, but from our standpoint, 17 is almost like an adult, correct? Girl, 17 is like an adult. Canine, just like that. Upper canine looks terrible too, but to me, upper canine is like a piece of cake compared to the lower canine. Why? Because we are now able to look at the center of resistance. Try to pinpoint the center of resistance. Now you see the canine, upper canine is a modest position. It's not really terrible. You can say the upper canine. But what about the lower canine? It looks terrible, and even if you pinpoint the center of resistance, it's still terrible. You pinpoint the center of resistance, even the center of resistance, they are transposed between canine and the lateral incisors. So you have to move through a long journey if you really want to save the canine. Is that going to be possible? And it's impacted on the lingual side. You want to try? Raise your hand. My lesson is don't try. Don't. Please, don't. Because I didn't have a very, very good experience either. I have nowhere to send the patient, at least in Korea. Maybe to Vietnam or some other country, but I have nowhere to send the patient. Lingual side exposed. And just because the whole body was relocated toward the midline, I had to move the whole thing to the lateral side using only single forces. That's not possible. And I used the class 3 leverage effect by using 2 forces, one on the bottom, another one on the top. Now, costive force will be directed to the, this is a typo. Costive force force of the positive will be directed to the medial side. Cervical lumbar button, force from your cervical lumbar button will be directed to the distal side. What does it mean? I want it to turn it upside down, moving the root all the way to the distal side. Barely able to save canine just like that, but this was also beginning of the nightmare. More than 2.5 years. How long did it take? Almost like 4 years. 4 years of my time, 4 years of hard time was spent to save the canine. Now I put the braces just like that for final torquing. Save the canine. But you see, recession on the lumbar side. She makes very, very artificial smile because I asked her to smile. She's freed from the orthodontic treatment for more than 4 years, 4.5 years. I don't know if she's really happy or lying, but I'm not happy because there was bone loss, root shortening or something. Why? Because my biomechanics was terrible? No, I was able to handle biomechanics, but not the biology. Why? Because she was 17, right? So what is the main issue? Treatment timing is important. From another article we published in JADA, we measured the bone loss, root resorption according to molar retraction. And one of the things we found interesting is that there was insignificant, just a little bit significant alveolar bone loss amount of root resorption, but the main factor related to alveolar bone loss was not necessarily the amount of movement. It was age, patient's age. If you grow older, no matter what you do, you lose a bone. So if you're concerned about bone loss, do it before it's too late, as soon as possible. Now, you integrate all this information I've given to you, and now I will give you a very, very creative solution. We have like 20 minutes left. 9-year-old man, boy, this is the same panoramic view I showed you. 23, 24, 25. You will send the patient to oral surgeon to get the surgical opening done. Okay, you do it and you will be in trouble. Why? Because the surgeon cannot do the work for you. Why? He cannot or she cannot access the canine without harming, without damaging the first premolar, unless they go through your nose cavity or something. You want to drag your wire all the way nose and then you go to America's Got Talent or something. So what am I supposed to do? Try to, this is a question. You want to do nothing or do something. We cannot do something right away. If you let it go, once again, if you just let it go, doing nothing, you are making it worse. That's very hard part. Why? Canine is coming up, canine will resorb the root apex of the first premolar. Is that correct? And erosion path of the canine will be messed up again. I don't know what will happen to impacted canine, so we cannot do nothing. We cannot do something. We cannot do nothing. We cannot wait. The best policy is to send the patient to your neighbor orthodontist, and then case closed, and that's it. But have a careful look at the case from a biologic standpoint. What matters is that basically we have to give a room to canine because canine is coming up, and we pulled the first premolar down. Oh my God, the first premolar has no root, but we got a lesson. Then this vertical force will give a woven bone on the apical side as long as there's no traumatic occlusion. It's a very good environment for the blah, 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 all those apical popular stem cells to work. You have to make them work by giving some environment. What environment? Loose bone, loose area, no trauma. And this kind of forced eruption is something good from a biological standpoint. Something strange, something exciting, something very extraordinary happened in the next 2 years of time. So the first molar root grows, it grows, and then canine was relocated by itself. Why? Because there's there's a magical powder or something sprinkled on the top of the canine. I mean, the canine eruption was something we didn't expect. We were going to have a better access to the canine. That's what we expected, but something like this happened. Okay, even without this, we were going to try surgical opening after first premolar root formation. So the point is, immediate forced eruption of the first premolar was something right. Is that correct? Is that correct? We did it right. Before, after forced eruption with no root growth, canine relocation, further canine relocation, and the whole treatment time was 5 years, 9 months, including all the observation time, no treatment, plus active treatment. This is the end of the treatment. Class 2 molar, because he was missing 2 lateral incisors. Good. And I call it Yonsei guided eruption, because no one ever tried something like this before. There's the only way I can name it. Yonsei guided. What does it mean? Forced eruption of the target tooth before the root formation. Intentional forced eruption. True. What's the rationale? To facilitate bone formation and root formation of the target tooth and also adjacent tooth. What's the take-home message? You want to understand that there's a nature, biology nature. Now, let's move to the final issue, ankylosis. You want to diagnose ankylosis? This one, no. You have to know ankylosis is surprisingly common. But from a biological standpoint, it is very amazing to see the tooth can erupt, the tooth eruption without ankylosis. How come this patency, how come this ligament structure is very well maintained throughout the long eruption process? If something goes wrong, there will be direct contact between the root surface and the bone surface. That is what we call ankylosis. You do history taking. Without trauma, there will be no ankylosis? No. Ankylosis happens so often. If you take some medicine or something, ankylosis happens. So, from now on, your attitude will be like when the patient comes, very good tooth, no history, no medication or anything. Even so, you start to suspect ankylosis of any particular tooth, right? So what you will do is to try perio test on every tooth, on every new patient, right? Especially before you extract some premolar, because extraction is irreversible. That's from biology. What does it mean? This ankylosis was not shown in axial CBCT. You cannot possibly diagnose ankylosis from CBCT, so you need to do some speculation. And if you fail to diagnose ankylosis ahead of time, at the very right time point, you know something like this will happen, correct? Okay, this is again published very long ago, more than 10 years. Very bad sequence of ankylosis of lower first molar. What is your speculation? It was not even easy to make a diagnosis about what was ankylosed. Was it second premolar or first molar? You really have to make a strategic decision. For example, if you pull out the second premolar, and if the first molar is ankylosed, then you are in deep trouble. Now, what is your kind of inspection, speculation? First molar is supposed to erupt 6. Because of the eruption of the non-eruption of the first molar, eruption of the second premolar was delayed. Now the third molar is getting on the top of the first molar, so possibly first molar is ankylosed. That is supposed to be our target tooth. She is 15 years after growth. There's no growth left, possibly, but even now the situation is terrible enough. It's like a nightmare. You want to pull out the first molar, and then there is a bone defect. You cannot possibly place a dental implant there. You can do that, but the prognosis will be unfavorable. Also, she was missing another second premolar and lateral incisor and things like that. But what is the most important was first molar. Bone. That's the bone. We have to make the bone, and you know how to make the bone now. Terrible. I'm sorry, you finish your lunch, right? Sorry, skip over this. It feels just so terrible when we see that kind of case. Feel like it's like, no, something like that. So, second molar, and we pulled out first molar right away without hesitation, assuming that we will pull the second molar forward by moving the root, not the crown, moving the root. For moving the root, we need a lot of moment, twisting action. So we engage the upright spring. Have a look at the second molar, it's terrible. But we want to move the root forward. What do we need? The cantilever wire produces a lot of moment because of the length. With a small force, length increases. Force multiplied by the length will be the moment. So we can upright the second molar by pure root movement. And then second premolar, according to our expectation, we were right. Second premolar was not ankylosed. Thank God that we say thank God on the side. After extraction, bone defect, after root movement, as if nothing had happened. So this is a result of a root movement. Then we finish the case at class 2 molar on the right, class 1 molar on the left, because of missing tooth in the maxillary arch. Before and after treatment. You want to do it again? Once you're done, you can do it again. But don't make it worse. This is the worst case scenario maybe. She visited pedodontic department when she was 9, and so the panoramic view was taken. Even the CBCT was taken, and nothing was done back then. At 9.7 years. Nothing was done for 2 years. Just observation on the side, doing nothing. So this ankylosis, discontinuation of the root surface, it's very obvious. When she was 9.7 years, very obvious. Something has to be done, but the pedodontist didn't do nothing. Why? Because she was not in my seminar. She didn't know what to do. She couldn't make the decision. 2 years later, this thing happened. Of course, it will happen. It's very obvious ankylosis. If the ankylosis is diagnosed from the radiology, it's very, very obvious ankylosis. And what troubles you is the ankylosis that is hardly diagnosed from radiology, right? So we need a little speculation, interrogation, or whatever. 11.4 years. What do you call this molar relationship? Is it class 2 molar? Or super class 2? Or super duper hyper class 2? It's a super duper hyper class 2, correct? Is it simple class 2? Huh? What is it? It's a hyper class 2. What about the second molar position? It's going on top, touching the upper gingiva. She's 11.4 years. 11.4. What am I supposed to do? Okay, time is running. I was like, this is an emergency, we need to do something, ring the bell, just like that. Emergency. We wasted even 2 years before. It didn't have to be this way, but 11.4 years, that was the time point she visited ortho. And we intruded right away. Okay, I have to place the implant, then mini screw today. We're not supposed to waste even a day. Intrusion to be able to pull the second molar forward. And what kind of appliance would we need? Because we need a lot of movement. Helical spring is way better than lever arm. Never ever think about lever arm thing. Never ever think about lever arm thing. That doesn't work. We need constant and large movement. And according to experimental outcome, even if we use a helical spring or uprighting spring, every time we have to reactivate, otherwise we don't get enough moment. So if we use a lever arm, it doesn't create sufficient moment at all. It wouldn't work when it comes to root movement. So try to use a helical spring. I will make a long story short, and we use the helical spring here, upright to the second molar first, and then still we have to rotate the whole arch to her left side for 2.5 years. Oh, it didn't take a very long time. We were lucky because I regard this as an emergency. We have to do something right away. So this is the amount of the root movement. How much was that? About 18 millimeter forward root movement of the second molar. 20, it says 20. Mesial displacement. We still have to keep an eye on the third molar because third molar formation is important for the completion of occlusion, correct? We monitor the circulation for the next 5 years. Wow, this is magical. Third molar is erupting and also uprighting by itself, in itself. Why? Because there's no obstacle in the front. There was no obstacle. This is a biomimetic orthodontics. On the other side, because there was an obstacle in the front, the third molar was not able to come up. So there's an obvious difference between right and left side. On the right side, we need the third molar, and it happened. And on the other side, we don't need the third molar, so we'll pull out the third molar. Complete. This is good outcome for the better life quality for the rest of her life. And I also have a look at the transition of the molar relationship. This is something we can do using recruiting good biomechanics and at the very right time point. The sooner the better. Try to remember. Extraction decision has to be made as soon as possible. Now, final question. We need a little bit of creative thinking. This is a case of ankylosed, the central incisor, not like the molar, the central incisor. We need to get crazy. We need to become a little more creative. What are you going to do for the ankylosed upper right central incisor? It is obviously ankylosed because of trauma, replantation history, obviously ankylosed. Yes. Dang, dang, dang is a sound we can get. Obviously. What are the treatment options? Single tooth distraction, osteogenesis, and things like I don't really want to do that because of possible necrosis. Don't really want to do that. Orthodontic surgery, segmental osteotomy, I don't really want to do that. That's too complicated. Is there any other way? Any other way? Try to be a little creative. Try to think about using the device in different way. Now we know how to intrude the whole arch, this and that way. We decide to intrude the whole thing except for ankylosed central incisor, using the central incisor as a vertical landmark. That sounds crazy, but that's not impossible either. There's no change in the central incisor position even by 0.1 millimeter because that was obviously ankylosed. We close again. Using multiple mini screws, buccal and palatal side, and this is an evidence. The length from the palatal plane to the central incisor teeth was absolutely maintained. There may be some graphical error or something, but everything except for central incisor was intruded. And you can design something like this, and you will see the reduction of the vertical dimension. Can you see that? This is more close to 5 millimeters. Again, from 3D CBCT, we try to measure the distance from the piliform aperture to this incisor edge teeth, which was almost the same, right? So except for the central incisor, everything else was intruded. Okay, let me summarize the whole thing so far. What did I say? Early diagnosis is crucial. If it's not ankylosed, early intervention using linear forces. I showed you the example, the single force here and there. It doesn't have to be vertical direction. Therapeutic diagnosis until confirmation of ankylosis, and if after confirmation of ankylosis, you may seriously think about early extraction followed by removal. Because if you let it go, everything will become more and more terrible. Timing is important. Are you interested in biomechanics? Come to Yonsei University. You will enjoy. There's a QR code. Register now. This year's program will be from June 24th, 27th to July 2nd. Main themes, next level orthodontics. Something like this. This is a simple example of what we will discuss during the program. Hopefully you will come and enjoy. Thank you very much for your kind attention.
Thank you very much for your presentation. It's very useful and super interesting. And we go to the questions.